Okay, everyone. So, welcome to the last and final day of looking back, moving forward, pharmacy practice after COVID-19. It is National Public Health Week, which extends all the way until Saturday. So, feel free to join in. Use the hashtag PharmD moving forward. Our NPHW is abbreviated for National Public Health Week. And I am Dr. Laquita Johnson. I am a population health consultant pharmacist. I empower patients to be proactive in their health. I empower I empower pharmacists to be frontline healthcare practitioners, and I impact the American healthcare system. So we have had an exciting week, and I have been giving giveaways all week. So today's giveaway is all of the above. Um, you can just follow these steps, like the Facebook page. If you already have, that's totally fine. Share this live stream, our video, and use the hashtag PharmD moving forward when you share it. And I will be looking out for it. So there's no time limit or anything. If you see this video, feel free to share. So then again, this includes your LinkedIn profile review, a resume or CV review, as well as a company Naplex mastermind call. All of these will be calls in general, and they will last about 30, 40 minutes. So feel free. I have been in practice a while, so I have a variety of background in my profession. So feel free to get any of the giveaways. So there has been exciting news, and I must have missed it yesterday, but today I found out that pharmacists that we have been authorized to order and administer COVID-19 tests, and that is a great and important move for us, for our profession, for us to be recognized. And I'm just so excited. As you see on the screen, we have been authorized to order and administer COVID-19 tests to help patients make easier access for them, because in community pharmacies are located within 5 or 10 mile radius of many neighborhoods. So we are the perfect location to host COVID-19 testing. In terms of how it will lay out and different things of that, I will be following this to let you know. I have heard a couple of things that I cannot disclose. However, it seems like it will be interesting when it does roll out. So I'm very excited for that news. So let's just dive into it. And for those of you who are joining in, thank you for joining in and listening to watching our live screen. We're just about to get started, so let's just get on in it. So one of the key things that I think is, how do we move from, here? How do we progress as pharmacists? And one of the things I think we can do is be a provider and have our provider status. That is something that we have been trying to check for a while now, trying to obtain for a while now. And I think it'll be a great thing. And for those of you who don't know what provider status is, according to the American Pharmacists Association, or APHA, pharmacists and pharmacist patient care services are not included in the key sections of the Social Security Act, which determines our eligibility for healthcare programs such as Medicare Part D. And in the case of Medicare Part D, we as in pharmacists have been consistently omitted as this is provider limitations for Medicare beneficiaries to assess our services in the outpatient setting. So that's one of the key things. And by us not being listed, it kind of limited what we can really do. Because as again I said, we have always been seen as healthcare professionals who just simply put pills in a bottle, but that's totally not what we do. I mean, that's more of a, in some cases we do, help technicians out, but it's not like our scope of practice and exactly what we do. So that's one of the things I want to make sure I put out. And then in many states, in terms of Part B, many states and private health plans, they often cite the omission from Medicare Part D for the lack of reason of coverage of beneficiaries or lack of compensation of pharmacists for providing comprehensive patient care services. So that's one of the main things. And because states omit us, it makes it very hard for us to, which it basically contributes to the variation in the scope of pharmacy practice regulations, in which every state has different laws, and pharmacists are not like other healthcare professions where you can be licensed in one state and potentially go practice in another state, or you can be in some type of professional group where they house groups of states where you can practice in, but pharmacists doesn't have that. We have to be licensed in every single state in order to practice, and that really hinders us because not only we have to be licensed in each state, but each state has its own scope of practice regulations that allow us to the own scope of pharmacy practice. For instance, California, states such as like California, North Carolina, New Mexico, Montana, they have created advanced pharmacy practice destinations to expand pharmacy scope of practice through collaborative practice agreements. New Mexico has been doing it since 1993, in which they have been recognized pharmacists as mid-level practitioners who manage primary care patients, and they have since expanded upon that, in which pharmacists are allowed to provide specialty care services as well as prescribing medications, performing physical exams, and ordering lab tests independently in collaboration with a physician. So I think that should be noted. And in California, they have an advanced practice agreements mentioned as well, and you take a certification and you have meet certain criteria. But even in that state, pharmacists can prescribe nicotine replacement products that support tobacco cessation if the pharmacist just completed training. So there are many states that are being proactive and advancing the scope of pharmacy practice. However, we have to collectively come together and be as a whole. And as a result of this, because pharmacists can't practice or because of the variation in the scope of practice, pharmacists are able to do what pharmacists are able to do once they graduate varies, because it's not related to our ability, our education, our training, or our safety concerns, but to the political decisions of that state in which we work in. So therefore, I would say it's very important for pharmacists to be proactive and advocate on that local and state level, because we are having laws and regulations being written and made by people who are not in our profession. So therefore they cannot attest to what we do, because the average lay person will say that a pharmacist simply put pills in a bottle and we do what the medical doctor says, which is far from what we do. So that is kind of why we need to be proactive and advocating for our profession. And I know it's kind of hard sometimes. We get caught up in our daily lives and we just want to complain, but we have to be proactive instead of reactive. And why is all this important It's because payers and policymakers, they have to recognize pharmacists as healthcare providers who improve access, quality, and value of healthcare. We have to access and coverage and provide coverage for pharmacist patient care services. We have to have that access because we have limited access through Medicare. Well, we have access through Medicare, but limited access through Medicaid and other federal or state health benefit programs. And pharmacists need to be included as healthcare team members. We have started, but there is more to come. So all week long, I have been hinting at exactly the MTM, the three trends, and today I just want to kind of drive that point home because you remember in the beginning on Monday session, I said that there are three trends in healthcare. It's the provider, the health plan, and the patient. And the provider, we know who that is. Like the provider can be medical doctors, nurse practitioners, etc. But if we have pharmacists, if we include pharmacists, we can be a trend by us simply being a provider in which health plans allow or say bill transfer their regulations and scopes to allow us to practice and be able to bill for our services in which we can impact the patients because we have already seen, as I mentioned earlier, that medication therapy management MTM is it's a program that pharmacists specialize in and which it has been proven to increase adherence as well as low healthcare costs because healthcare costs is almost I think $1 trillion or more every year, especially in chronic disease. And certain disease states are different outliners. So we really have to we really have to come a long way and really have to provide. And I think our response to COVID-19 is a stepping stone and it's all about what we do from there and where do we go. So you have to think past COVID-19, even though I know it's very hard, but we have to. And one of the best things I think we can do is have collaborative drug therapy management agreements. And for those of you who do not know, is that a collaborative drug therapy agreement is enabled by what I mentioned earlier, a collaborative practice agreement, in which all it's doing is developing an agreement between one or more healthcare providers and pharmacists, in which the collaborative practice agreement qualifies pharmacists for working in the context of like a defined protocol to assume like different responsibilities such as like counseling, ordering laboratory tests, administering drugs, as well as selecting, initiating, and adjusting drug regimens, aka things we do with MTM a little bit. We just make recommendations, however, though. That's one of the things that it can do. And the collaborative drug therapy management, it really allows us to expand our scope of practice, and which is a it has been proven to be a cost effective strategy for lowering blood pressure, blood sugar, LDL or cholesterol levels, as well as improving treatment quality and increasing medication adherence. It has been the implementation is moderate. The health impact it has been highly supported. For example, you have partnerships that were in states such as Minnesota, Iowa, Arizona, in which, for example, even North Carolina, because in North Carolina they had a study back in, I want to say, I can't think of exactly when it was, but they had a, I know in Minnesota they had a study back into the 80s, in which you had Goodrich Pharmacy, which was a locally owned pharmacy. They provided services into, they began entering medication substitution agreements for like the local doctors, in which that they provided intensive medication therapy management, MTM, patient care services through the CPAs, and which it was the foundation to pharmacy practice now. They were the pioneers of MTM, you can say. But you do have states such as North Carolina, that which you have the Asheville Project, and they have a clinic where it's a pharmacy provided care for controlling diabetes, high blood pressure, and high cholesterol. And their efforts save had a net saving of between $1,600 to $3,500 per year per patient, and that's just by having a pharmacist there. It also improved the patient health as well, because there were over patients had there was a 50% average reduction in the number of sick days for patients, as well as in terms of diabetes. You know, you have your A1C, your your A1C, and then you, and with those that had A1C and screening rates which improved by 97% just by pharmacists alone. So there are one of the key things to happen. So in all, I really think that what we should do past, and it's just my opinion, but what we should do past COVID-19 is really truly focus on provider status. But if we can't achieve that, because I mean, we have been trying, I know, for the last 7 years and nothing has changed. But one way we would think, one thing we can do is start beginning collaborative practice agreements, and utilizing collaborative drug therapy management, which are enabled by the CPAs. So I really think that's one of the future of us, what we can really do. Let me know if you agree in the comments. And I really want to thank you guys for joining me this week. It has been a pleasure. I have had so much fun.